Hello everyone. Now we'll do some menstrual abnormalities that we commonly see in gynec. So for that you have to know about the normal menstrual cycle. We know what is menstrual cycle. It is a cyclical pattern of the activity of hypothalamus, pituitary, ovary and uterus that produces a rhythm of bleeding every month for 30 or more years during the active reproductive phase of a woman's life. So this complete definition gives all the aspect of the menstrual cycle. And menarche is the first flow that occurs, and the menopause is the termination of the menstrual flow that also determines the diminished ovarian function. So now we know what the maturation of the hypothalamic pituitary ovarian axis is the main thing for a menstrual cycle to occur, and the hormone produced are GnRH from the hypothalamus, which stimulate the FSH and LH from the anterior pituitary, and this FSH and LH stimulate estrogen and progesterone from the ovarian follicles. So that's the flow that occurs from hypothalamus till the ovarian follicle, releasing the estrogen and progesterone, and then the action on the external genitalia and the secondary sexual features. Now, endometrium consists of two layers. That is, the one is functional superficial layer, which gives a which is degraded or slowed off in the cyclical changes in the menstrual cycle, and it mainly consists of the spiral arterioles, and these undergo spasm when there is progesterone withdrawal, and that leads to the slowing of this layer. And then there is basalis zone, which is deeper zone. The superficial layer is mainly called functional zone, and the deeper layer is called the basalis zone. It remains unchanged in the menstrual cycle, and it contains stem cells for the function and to renew the functionalis every time it's slowed off in every cycle, and it consists of the basal arteries. So now we can come to the menstrual cycle phases. There is follicular phases. Okay, first of all, so first on the we'll see the different phases and how the hormonal changes occur with each phase of the cycle. So first is proliferative phase. This proliferative phase follows the menstrual phase. The menstrual phase, okay, we can say if the menses occur on the day one, like this, okay. So post menses, which lasts for 2 to 5 days, then occurs the proliferative phase. So this proliferative phase uh, is characterized by growth of endometrial glands due to estrogen stimulation, and the stem cells are dividing that migrate through the stroma to new epithelial lining of the endometrium and new endometrial glands, and the length of the spiral arteries is increased, and we get an estrogen dominant phase, estrogen dominant endometrium, and this is very unstable, and it can undergo hyperplasia with the irregular shedding over the time if it is not shed on time. Now next phase, menstrual phase, menses, then proliferation. Now what will happen? There is secretory phase. The secretory phase, mainly is characterized by glandular secretion like glycogen, mucus, okay, glycogen and mucus secretion due to progesterone from the corpus luteum, and in this case the endometrial stroma becomes edematous and the spiral arteries become more convoluted. So this is a progesterone dominated phase. Okay, and it is stable and it does not undergo irregular shedding, and the regression of the corpus luteum occurs by the day 23, and if there is no pregnancy, and then it causes the decreased level of progesterone and estradiol, and there is endometrial involution. Constriction of these spiral arteries occur one day before the menstruation, which cause the endometrial ischemia, and that releases the prostaglandins, followed by the leukocyte infiltration and RBC extravasation. The resulting necrosis leads to the painful cramps and menstruation of the menstrual cycle. And if there is pregnancy, then the beta HCG level becomes positive at the day 22 to 23. And this beta HCG becomes positive when the zygote implants in the endometrium, and when it occurs on the day 7 to 8 after ovulation. So serum beta HCG becomes positive before the missed period. So we can check for it before the missed period. We can check it in serum, we can check it in urine, in the UPT, and that's how the menstrual cycle works. Menses occur. There is proliferative phase, estrogen dominant. Then there is secretory phase, which is progesterone dominant, and then there occurs the hormonal change with decreased progesterone and increase constriction of the spiral arteries and menstruation subsequently due to the endometrial ischemia and the release of prostaglandins. So the prostaglandin released here, it is also cause of the primary dysmenorrhea that girls usually have with the that is relieved with NSAIDs. Primarily we give NSAIDs for it, and like ibuprofen can be given. And so let's discuss about the hormones. So hormones mainly that are important, we have seen FSH and LH. So what does FSH do? FSH causes the growth of granulosa cells. And what does granulosa cell do? It secretes aromatase enzyme that converts androgen to the estrogen. Okay, so FSH. So FSH causes granulosa cell to form aromatase enzyme that converts androgen to estrogen. Okay. And it raises the concentration of its own receptors on the granulosa cells. It stimulates the secretion of inhibin from the granulosa cell and is suppressed by the inhibin. See, granular cell will also cause inhibin secretion, but this increased inhibin is also causes the negative feedback and decrease the FSH. Okay, and now we come to the LH. This was FSH action. Now we come to the LH, luteinizing hormone. It stimulates the production of androgens by theca cells. So we already studied that in previous videos, and that get converted into estrogen in granular cells by the aromatase enzyme. So its main cause is producing androgen by theca cells. So it stimulates theca cells, they produce androgen, and we know granular cells have aromatase, they convert androgen into granulosa cell. So that's the thing. So always remember, FSH acts on the granulosa cell, LH acts on the theca cell. Theca cell gives androgen, and granulosa cell forms estrogen from androgen by the enzyme aromatase. Now, what does this LH do? It raises the concentration of its own receptors wherever there is FSH primed granulosa. FSH primed granulosa, FSH has already have stimulated the granulosa cell. So wherever there it is, so there it raises the concentration of its LH receptors. So more LH comes and bind to its receptor, more effect to what? Theca cell will more androgen, and this more androgen will be converted from granular cell to the estrogen. That's why. So sorry, that's why it requires the FSH primed granulosa cell, and that leads to the LH surge, and it leads to the rapid rise in the estrogen level, and which stimulates the prostaglandins to enhance the follicular rupture. As the follicle ruptures, so there is ovulation, and the LH surge also promotes the luteinization of the granulosa cells in dominant follicle, and that leads to progesterone production as early as 10th day of the cycle. So what it does is luteinization of the granulosa cell in the dominant follicle that has been chosen. It results in the progesterone production. Now let's go to the main female hormone, the estrogen and progesterone. Direct estrogen, we have seen it is produced in granulosa cell in response to the low FSH concentration, and stimulates the proliferative endometrium effects. It is negative back. It is a negative feedback on FSH at the hypothalamic pituitary level, but it also has a positive feedback to increase GnRH receptor concentration. In case, okay, so when the estrogen is low, there is negative feedback to the LH release, but as the level of estradiol increases and is more than 50 or 40 to 50 hours, then there is transition to a positive stimulatory effect, and that leads to the LH surge. Okay, so in what I say in starting, if there is estrogen is low, it at low levels it will inhibit the this estrogen will inhibit the LH, and LH inhibitory feedback for the LH release, and but when the estrogen is high, so it will go on the positive feedback, and it will lead to more LH release, and that leads to the LH surge. Now there is another hormone, androgen. Mainly androstenedione and testosterone. They are the precursor of estrogen. We already know that the androgens are produced in theca cell under the effect of FSH, and then they are converted to estradiol in the by aromatase enzyme from the granulosa cell. And in lower concentration of androgens, the aromatase enzyme is stimulated, but if there is higher concentration of androgen, so the enzyme will be inhibited. So what does an androgen inhibit? FSH induction of the LH receptors. Okay, where you remember the FSH primed granulosa cells were the main target for LH receptors, and that caused the surge of LH. So this androgen inhibits the FSH induction of the LH receptors. Now comes the progesterone, which is produced by the corpus luteum, and it stimulates the secretory changes in the endometrium in preparation of the blastocyst implantation. So these were the hormones. I'll again repeat just once for so that you are clear in your mind. So FSH, what it does, acts on granulosa, secrete aromatase, androgen to estrogen, and it raises its own concentration of its own receptors on the granulosa cell, and it stimulates the secretion of inhibin also from the granulosa cell, and it is also suppressed by inhibin. Now comes the LH. LH acts on theca cell, convert estrogen into granulosa and convert it to estrogen into granulosa cell by aromatase enzyme. Two cell theory we call it. Now it raises its concentration of its own receptor wherever there is FSH prime granulosa, and the LH surge is dependent on a rapid rise in the estrogen that stimulates the synthesis of prostaglandins that enhances the follicular rupture and the ovulation, and the LH surge promotes the luteinization of the granulosa cell in the dominant follicle that results in the progesterone production as well as on the 10th day of cycle. Now, estrogen is directly produced by the granulosa cell in response to low FSH concentration, and it stimulates the proliferative changes in the endometrium. It has a negative feedback to FSH at hypothalamic pituitary level, and it has positive feedback to the GnRH concentration. So when estrogen is low, so negative there is estrogen is less, so there is negative inhibitory feedback for LH release. But as the level of estrogen increases and is sustained for a long time, then the transition to a positive stimulatory feedback occurs that leads to the LH surge. Now, androgen is two types, androstenedione and testosterone, and they are precursor of estrogens produced in the theca cells. So, in low concentration, the androgens stimulate the aromatase enzyme, whereas at high concentration, they inhibit. Okay, of course, if something is already high, why will you produce it? Okay, and progesterone is produced by the corpus luteum, and it stimulates the secretory changes in the endometrium in preparation for the blastocyst implantation. So now occurs vaginal bleeding, that is premenarcheal vaginal bleeding that occurs before the menarche. So that can be due to any ingestion of estrogen or medication or any foreign body that irritates the vaginal lining, and any cancer of cervix, that is sarcoma botrytis, in which there is grape like lesion coming out, or any tumor of the pituitary or adrenal gland, or any sexual abuse or any trauma to the genital tract can lead to this bleeding. And we can diagnose it with pelvic examination directly, and under the sedation we have to do, and in this examination we can see any foreign body, sexual abuse, tumor, and imaging. If we have to do, we can do CT scan and MRI of the pituitary and abdomen and pelvis, and see if there is any tumor associated with the early estrogen production. Now we come to the abnormal vaginal bleeding. So in first of all, in pregnancy there is abnormal vaginal who have abnormal vaginal the patients who have abnormal vaginal bleeding during the reproductive age group, pregnancy or a complication, they must be treated, they must be taken in consideration first, because complication of early pregnancy are associated with bleeding and due to incomplete abortion, or there is threatened abortion or ectopic pregnancy, and we have already learned about the hereditary mole. And how can we diagnose it? With beta HCG, urine or serum to diagnose pregnancy. If it is not identified, we can go for vaginal ultrasound, and management is mainly whatever the pathology is, just treat it. And next we can see abnormal vaginal bleeding with the anatomic any lesions present there which are causing bleeding, or various vaginal lesion, laceration, varicosities, tumors, polyps, or myometrial lesion like adenomyosis also cause a lot of bleeding, and endometrial lesions like uterine fibroids which are submucous leiomyomas, and polyps and hyperplasia can cause bleeding. So for them we diagnose the anatomic abnormality, by pelvic and speculum examination of the lower genital tract, and for the upper genital tract we use hysteroscopy, or we can do biopsy of some suspicious lesion and saline sonogram, and we can manage that accordingly. Now, other cause of abnormal vaginal bleeding can be any coagulopathy which is inherited. So it can be due to vessel wall disorder or platelet disorder or coagulation disorder or fibrinolytic disorder. And we also come across von Willebrand factor deficiency a lot, or that is also a main cause, because it is von Willebrand is required for the platelet addition. So what we'll see, like positive family history of coagulopathy, and we'll see CBC with platelet count will show the numbers decreased, and we can see the PT or PTT according to the extrinsic or intrinsic coagulating pathway that has been included. So the best screening for von Willebrand is to go for the von Willebrand factor antigen, and we can manage it accordingly with the consultation to a hematology department, and whatever is the pathology. And now the dysfunctional uterine bleeding can occur, in which there is no pregnancy, no anatomic cause of bleeding, no coagulopathy. So there is hormonal imbalance which can be a major cause, and the history is unpredictable bleeding in amount and duration and frequency. There is no cramping, and there is anovulation is the most common cause of such type of bleeding due to an unopposed estrogen. So unopposed estrogen is continuous stimulation of endometrium with no secretory phase. So estrogen dominant endometrium is structurally unstable. We saw it in the menstrual cycle. So it is increasingly thickening. So with inadequate structural support, it eventually undergoes random, disorderly and unpredictable breakdown, resulting in the estrogen breakthrough bleeding. So these anovulatory cycle can be diagnosed from the history of irregular or unpredictable bleeding, and bleeding is usually without any cramping because there is no prostaglandin release, which causes the myometrial contraction. There is no release of that. Cervical mucus will be clear and thin and watery, and that will reflect the estrogen dominant environment. And basal body temperature will not show because it is dependent on the progesterone thermogenic effect of an endometrial biopsy will show a proliferative endometrium instead of secretory. And there are many causes for this AUB. We call it AUB, abnormal uterine bleeding, and the main mnemonic is palm coin that we study in our undergrad also. That is polyps, adenomyosis, leiomyoma, malignancy, coagulopathy, ovulatory, endometrial, iatrogenic, not classified. So what we can do it in, we can do progesterone withdrawal test in such case. So progesterone trial can be given. So what does that progesterone do? It will stabilize the endometrium and stop the bleeding, and it will prevent the random breakdown. So when the progestin is stopped, so the spiral artery spasm will result in the prostaglandin release, then subsequent necrosis, and then shedding of the superficial endometrium. So positive progesterone trial will confirm that there is an ovulation, and if there is negative progesterone trial, then there is estrogen deficiency that is occurring. Okay, so anovulation can be secondary to any medical condition also. They can be hypothyroidism, because hypothyroidism is also causing the anovulation because TSH is high TSH, and high TSH, and it is usually treated with the thyroid replacement if it is asked in question. And in hyperprolactinemia also, the serum prolactin test we can do, so it will be increased. Prolactin we know inhibits GnRH, and that leads to increased dopamine, and that leads to increased prolactin, and there is no ovulation. because GnRH is inhibited by the prolactin directly. Now, progestin management that we can do is we can replace the hormone that is deficient, like if there is progesterone or progestin, and this method will regulate the menstrual cycle, and it will prevent the endometrial hyperplasia also. So we can give medroxyprogesterone acetate for 7 to 10 days of each cycle, and we can give OCPs, that is estrogen progestin OCP, that are used for convenience. The important ingredient is progestin, not the estrogen in these OCPs that we want. And the progestin intrauterine system like LNG IUS can be given, like Mirena and Skyla. They will deliver the progestin directly to the endometrium, and the treatment will significantly decrease the menstrual blood loss. Other treatments that are used, like NSAIDs for the dysmenorrhea or to improve the clotting and reduce the menstrual blood loss, they can be given around 5 days of cycle, and they can be combined with the oral contraceptive. Trenexa inhibits the fibrinolysis by the plasmin, so it is contraindicated in patient with history of DVT or pulmonary embolism, because yeah, and endometrial ablation can be done to destroy the endometrium by heat, cold, or microwave. And Asherman syndrome we can see, or and there is it's very common with it, and fertility is affected because of the additions. And hysterectomy is just the removal if it is the last thing that we can do if the bleeding is not stopping, and is usually done as a last resort if nothing works. So now we can discuss about various causes of primary amenorrhea, which is very important. So amenorrhea, what is amenorrhea? It is the absence of menstrual bleeding. So primary means the menstrual bleeding that has never occurred. So when do we diagnose it? That is the absence of menses at the age of 14 if no secondary sexual character develop, and at the age of 16 if the secondary sexual characters have developed. So it can be due to two main things. It can be anatomical or hormonal. So anatomical, we know either the vaginal septum is there, or imperforate hymen is there, or there is no uterus in Mullerian agenesis. Hormonal, we know it can be a complete androgen insensitivity, or there is Turner syndrome. Ovaries are streak ovaries. There are no ovulation will occur in that. There is hypothalamic pituitary insufficiency. And so what can we do? We can examine the patient first. We can see the secondary sexual characters, if they have developed or not. And if there are developed breast, that means adequate estrogen production is going on. If there is no breast, that means there is inadequate estrogen. If there is then we can see if there is uterus or not. So ultrasound of pelvis is important to assess the presence of a normal uterus first. So that will rule out the Mullerian agenesis. And there is also a question that keeps on coming, and we get confused between Mullerian agenesis and androgen insensitivity. So Mullerian agenesis, we know there is no uterus, and estrogen is from the ovaries, and there is pubic hair, and there is no hormones. So for treatment we don't need any hormone, we just create vagina, and they can have IVF surrogate for the kids. In androgen insensitivity, the karyotype is 46XY. So uterus is absent, and there is estrogen from the we'll see estrogen mainly because there is androgen insensitivity, so estrogen effect is there. And we'll see pubic hair, since there is no testosterone, so external male genitalia doesn't form. The pubic hair uh, develop in the action of the testosterone that is absent, and treatment of the androgen insensitivities. We can create the vagina, remove the testes, and give estrogen for development of the secondary sexual characteristics. Now, there can be other causes like hypothalamic pituitary failure is there, excess failure. So follicles are not stimulated, everything is normal, there is ovaries that are normal, and the estrogen progesterone challenge test produces the ovulation, and to test it we have to do see the MRI of the brain to check the hypothalamic and pituitary pathology. And gonadal dysgenesis is like 45x. There is no ovarian follicles, streak ovaries like in Turner. And for the treatment and for the pregnancy, we need a egg donor, and uh, we have to get an estrogen and progesterone for it. And so there is also a triad of Kallman syndrome, that is primary amenorrhea with no breast but there is uterus, and there is anosmia, and this is a triad important. And how can we approach it? Like based on findings of like breast and uterus, how can we divide and diagnose? So if there are breast, if there is uterus, so we have to look for if the hymen is imperforate or there is any septum, or is the hypothalamic pituitary axis is immature, there is due to anorexia nervosa, or excessive exercise, BMI is less than 18, and that will help us to go through these diagnoses. Now if uterus is absent but breast is present, then we can see it can be Mullerian agenesis, which is also called Mayer-Rokitansky Kuster-Hauser syndrome, and complete androgen insensitivity, which is testicular feminization, the XY karyotype. And we can see the testosterone level and a karyotype to make the diagnosis. And we already studied about both of them. And the main treatment for Mullerian agenesis is surgical elongation of vagina so that they can have satisfactory sexual intercourse. And the in androgen insensitivity we can remove the testes at around 20, and the higher temperatures are associated with intra-abdominal position of testes, so they may lead to testicular cancer. So that's why we remove the testes and we replace the estrogen. And in gonadal dysgenesis like Turner, what we can do, we can replace estrogen and progesterone for the development of secondary sexual character. And for the people who have immature hypothalamic pituitary failure, or so we give estrogen and progesterone for development of secondary sexual characteristics. So this was primary amenorrhea. So for first, what you have to do in primary amenorrhea, first the diagnosis: 14 no sexual characteristics, 16 with sexual characteristics, the menses appearing, and you have to see if there is uterus present or not with the pelvic ultrasound first. Then you have to see the secondary sexual characters, the breast present or not, the pubic hair, and the cycle, and depending on breast and uterus, you can divide into various causes and you can do further investigation as we discussed. Now what is secondary amenorrhea? That they have already had menses, but now for some reason for past 6 months they are not having menses. And that means it can be due to any cause. First of all, what is it? In a reproductive age, it can be pregnancy. So, or in other causes can be ovarian follicular failure, early ovarian follicular failure, that is less than 40. Premature ovarian failure occurs less than 40 years. All the ova are over and there is no more egg to fertilize. And there is any uterine or outflow tract pathology, there is any adhesions. So in pregnancy we'll just do beta hCG to diagnose the pregnancy. In an ovulation, what we'll do progesterone withdrawal bleeding. So if there is an ovulation, it will be associated with unopposed estrogen stimulation of endometrium. So initially the anovulatory patient will demonstrate amenorrhea, but as the endometrial hyperplasia develops, irregular and unpredictable bleeding will occur, that we have already discussed. And it can be due to PMOS, hypothyroidism, pituitary adenoma, elevated prolactin. Medications like antidepressant SSRIs and SNRIs are do this. And there is other things like estrogen deficiency is there, no problem, due to hypoestrogenic states, due to ovarian follicle failure or hypothalamic pituitary insufficiency, or then there is an outflow tract obstruction. So how we'll manage this? First do the pregnancy test, then do the thyrotrophic test, TSH level. If beta hCG is negative, hypothyroidism is ruled out with the TSH, and the elevated TRH in the primary hypothyroidism lead to elevated prolactin. So that prolactin prevents the GnRH release, that leads to the anovulation. Now you can see for prolactin level due to medication like SNRI, SSRI, antipsychotic, and you can see for any pituitary tumor, an idiopathic cause, and any progesterone challenge test, then we have to see positive or negative. Positive means that is there is an anovulation, and we have to give a cyclic medroxyprogesterone acetate to prevent the endometrial hyperplasia. And in negative, absence of withdrawal bleeding is caused by either inadequate estrogen priming of the endometrium, or there is an outflow tract obstruction. Now estrogen progesterone challenge test, if the progesterone challenge test is negative, so we do administer on the day 10, day 21 the oral estrogen, and then followed by the 7 days of medroxyprogesterone acetate. So if the positive is when there is degree of withdrawal bleeding is diagnostic that there is inadequate estrogen. So then we do FSH level to help identify the etiology. If there is elevated FSH level, there is ovarian follicle fail or ovarian failure. And if less than 25, the cause could be there is Y chromosome mosaicism with any malignancy. So we'd order a karyotype. And Savage syndrome or resistant ovary syndrome is a condition in which follicles are seen in the ovary by sonogram, but they do not respond to gonadotrophins. So they are not undergoing the changes according to the gonadotrophins. And then there is low FSH that can occur with the positive EPCT. So in that case, we know there is hypothalamic pituitary insufficiency. So we'll rule out for any brain tumor, and we'll see for any osteoporosis or any estrogen deficiency morbidity. So we can do what we can do, we can replace the estrogen, use the estrogen replacement therapy, and we can also give cyclic progestin to decrease the endometrial hyperplasia by estrogen. And the negative estrogen progesterone challenge is there is no bleeding, that means there is outflow tract obstruction, or there is scarring of endometrium, that is Asherman syndrome. So we'll do a HSG, that is hysterosalpingogram, and we can see the where the blockage is, and normally the treatment is hysteroscopic adhesion lysis. Then we followed by the estrogen stimulation of the endometrium, and then we use the inflatable stent then it is placed into the uterine cavity, and that prevents the re-adhesion of the uterine walls. So these were the main causes of the primary and secondary amenorrhea. and how we treat it, how we diagnose is both the progesterone challenge test, positive and negative, estrogen progesterone challenge test, positive and negative, and in positive we do the FSH level to differentiate ovarian follicle failure from the hypothalamic pituitary insufficiency. So that is how we approach the primary and secondary amenorrhea.